And without further ado, getting right into our feature presentation, I'd like to introduce today's speaker, Dr. Diva Sharma. Dr. Diva Sharma is an assistant professor of hematology oncology and transfusion medicine at Vanderbilt University Medical Center. Her clinical and research interests are focused on the study of reproductive health-related morbidity in women with sickle cell disease. She is a previous recipient of awards from the Foundation of Women and Girls with Blood Disorders, Thrombosis, and Hemostasis Societies of North America and Celgene to study the epidemiology of acute vaso-occlusive pain associated with menstruation in women with sickle cell disease. She serves as co-chair of the NLHBI Sickle Cell Disease Pregnancy Working Group, former co-chair for Research and Publication Subcommittee for the Foundation for Women and Girls with Blood Disorders, co-chair of the International Delphi Panel on Pregnancy Management in Sickle Cell Disease, and active member of the Society of Hematology Maternal Morbidity and Mortality Working Group. So without further ado, thank you so much. Help me welcome Dr. Diva Sharma.
Thank you so much for that very kind introduction. I'm very excited to be here today and talk about a topic that I'm very passionate about, acute vaso-occlusive pain associated with the menstrual cycle in women with sickle cell disease. And as Nayani mentioned, I'm a hematologist in transfusion medicine at Vanderbilt in Nashville, Tennessee, where we have a sickle cell disease center of excellence and where I've had great mentorship to study women's health challenges in sickle cell disease. Next slide, please. In terms of conflicts of interest, I've been a paid consultant for Terumo Blood and Cell Technologies to study the role of transfusions in pregnant women with sickle cell disease. And I've served as a medical advisor for SC Red, which is a fantastic national nonprofit organization focused on reproductive health challenges for people living with sickle cell disease. And I'm also a medical advisor for the Foundation for Women and Girls with Blood Disorders. Next slide, please. So I'll begin with a case presentation, which will highlight the significance of the problem of acute pain associated with the menstrual cycle. I'll talk a little bit about the epidemiology, what we really know about the prevalence and natural history of menstruation-related morbidity in women with sickle cell disease. And then I'll talk a little bit about management and prevention strategies for acute vaso-occlusive pain associated with menstruation. And I'll conclude by talking about the gaps in our current knowledge and future directions. Next slide. So I'll begin with our case presentation. This is a 25-year-old pharmacy student with sickle cell anemia, hemoglobin SS disease, and she's adherent to her hydroxyurea therapy. She's missed 16 days of school over the last 4 months due to acute vaso-occlusive pain episodes occurring around the time of her menstrual cycle. And her labs are notable for an MCV of 114 from a baseline of 81, signifying that she really has been adherent to her hydroxyurea therapy, and her hemoglobin on evaluation is 7.9. Next slide, please. So, scope of the problem, what is it and why is it important? Acute vaso-occlusive pain episodes are the most common sequelae of sickle cell disease. 97% of hospitalizations for people with sickle cell disease are related to acute pain, at least on admission. And the frequency of acute pain episodes not only predicts disease severity, but actually is a predictor of mortality in sickle cell disease as well. And so prior data by our group have suggested that women experience higher rates of acute vaso-occlusive pain overall than men. And these are extrapolated data from the largest prospective sickle cell disease cohort study. And you can see here that particularly around the time of menstruation, the gap between men and women with respect to frequency of acute vaso-occlusive pain episodes is quite pronounced, raising the question about whether the ovulatory and menstrual cycle contribute to this gender disparity. Next slide, please. So based on these data and clinical observations, that women were being hospitalized more frequently around the time of their menstrual cycles, we hypothesize that there is a subset of women who regularly experience acute vaso-occlusive pain episodes that are temporally associated with their menstrual cycles. Next slide, please. And so to begin, we really wanted to capture the voices of patients, hear about patient experiences in small focus groups, and help actually have the patient voices guide our future research in this area. So living in Nashville, we conducted 3 focus groups total. Two were in Nashville and 1 was in Atlanta, Georgia, at the SCDAA meeting. And so our goals of the focus group were to qualitatively document the pain experiences of menstruating women with sickle cell disease, and then to test the hypothesis through the patient experiences that these participants could actually distinguish their vaso-occlusive pain episodes associated with the menstrual cycle from their dysmenorrhea. In other words, asking the patients, can you tell the difference between your sickle cell cramps and your sickle cell pain around the menstrual cycle? Because some people had said to us, you know, they're just experiencing menstrual cramps. This isn't a real entity, but we wanted to hear from the patients to prove otherwise. So this is a quote from a woman who regularly experienced acute pain associated with her menstrual cycle, who participated in one of the focus groups. She said, "My menstrual cycle directly correlates with my sickle cell. The losing of the blood would automatically put me into crisis, automatically. So immediately my back would hurt, my legs would hurt, and I knew before my cycle started that I was going to have my cycle by my sickle cell pre-warning." Next slide, please. So that statement is pretty profound and suggests that this is a profound entity in some women with sickle cell disease. So we next went on to survey women with sickle cell disease if they can distinguish their acute pain from dysmenorrhea. And you can see here that when we asked the participants, can you distinguish your sickle cell pain from your menstrual cramps, 79% said they could actually make this distinction, suggesting that this is not just menstrual cramps causing discomfort. Like, this is an actual clinical entity that needs to be addressed. And one woman said nicely, "I don't know if I have cramps as bad, but I have them, don't get me wrong. I can distinguish from a cramp and my sickle cell pain. Let me put it like that." Next slide. So after this survey data and focus group data that suggested that there are a subset of women who regularly experience acute pain associated with their menstrual cycle, we wanted to quantitatively validate the findings of that focus group. Specifically, we wanted to estimate the proportion of women who actually experience acute pain associated with their menstrual cycle. We didn't know if this is a small portion of women, half of women with sickle cell disease, more than half. We really wanted to get a better capture of the epidemiology. Next slide, please. So we created a multi-center cross-sectional study in collaboration with Michigan State University. So our discovery cohort consisted of 103 women from either Nashville, Tennessee, or Detroit, Michigan. And these patients completed copies of 4 self-administered surveys that specifically asked focused questions about whether they regularly experienced acute pain associated with their menstrual cycles. And then we had a replication cohort because we wanted to validate the findings from these women who were followed in tertiary academic, sickle cell disease centers of excellence to sort of the broader population, also including women who may not be regularly followed with, a sickle cell disease center of excellence, to make sure that there wasn't some type of selection bias in our research. So the replication cohort consisted of women across the country who, if they had sickle cell disease, were able to access this online survey and answer the same set of self-administered questions. Next slide. So between the discovery cohort and replication cohort, again, women who completed the paper survey from 2 academic centers versus the women across the country who completed the online survey, we found that the mean age of women responding to these surveys was about 25 to 28 years. The majority of patients had the more severe genotypes of sickle cell disease, hemoglobin SS and hemoglobin S beta 0 thalassemia. Interestingly, the replication cohort reported a higher rate of hydroxyurea use than the group followed at an academic medical center. But perhaps, you know, the women at the academic medical center were on other disease-modifying therapies like red cell exchange transfusions. And you can see there at the bottom that more women at the academic medical center were on regular blood transfusion therapies for disease modifying therapy. But overall, the differences in these baseline characteristics did not meet statistical significance. Next slide, please. So when we surveyed the women, over 220 women in this cross-sectional study, approximately 80% of them said they had difficulty with activities of daily living during menstruation. That's a very, very high number that raised alarm bells for us. We specifically asked the participants, how many days do you have trouble taking care of yourself, such as dressing, going to the bathroom, showering, because of sickle cell pain during this menstrual period? And you can see that the majority of respondents said, yes, I do experience difficulty with daily activities, either a few or some days or many or every day of my menstrual cycle. Next slide, please. So then we wanted to go a step further and actually understand what proportion of women with sickle cell disease who are having regular menstrual cycles are actually experiencing acute vaso-occlusive pain with every or almost every menstrual cycle. And we saw that almost a third of patients reported experiencing acute pain associated with their menstrual cycle. And among the patients who experienced pain with their menstrual cycle, a number of them also had dysmenorrhea. And then about a third of patients said they had neither dysmenorrhea, meaning menstrual cramping, nor sickle cell pain with their menstrual cycle. Next slide, please. So then we wanted to understand this 1/3 of the population better who reported that they almost regularly experience sickle cell pain with their menstrual cycle. We wanted to know specifically, are there any risk factors for having this condition? So we did a multivariable and univariate regression analysis, and we looked at variables such as age, sickle cell genotype, use of hydroxyurea therapy, blood transfusions, baseline frequency of sickle cell pain, and daily sickle cell pain. And really the only factor which positively correlated with having acute vaso-occlusive pain associated with the menstrual cycle was dysmenorrhea. So in other words, the only risk factor and strong risk factor that we identified for having sickle cell pain with the menstrual cycle was also having menstrual cramps. And you can see here that the odds ratio was 8, and this did reach statistical significance. Next slide, please. So then we wanted to think a little bit about how could this be linked from a pathophysiology perspective? Why is dysmenorrhea, or uterine cramping, linked to experiencing acute vaso-occlusive pain with the menstrual cycle? So we hypothesized that there may be multiple mechanisms involved. Prostaglandins are increased during acute vaso-occlusive pain episodes compared to patients with sickle cell disease who are at their baseline state. But prostaglandins also mediate uterine muscle hyperactivity as well during contractions and dysmenorrhea. So we hypothesized that prostaglandins could be a link. And we also, noted in the literature that prostaglandins have been associated with decreased oxygen affinity of sickled red blood cells. So that could be another mechanism by which, the experience of dysmenorrhea or uterine cramping associated with prostaglandins is actually feeding into the same mechanisms that cause sickle cell pain. Next slide, please. And so NSAIDs are used to, like non-steroidal anti-inflammatory drugs like ibuprofen and Motrin are used to block prostaglandins. And so we did hypothesize that NSAIDs may be helpful to treat or prevent not only dysmenorrhea, but acute pain associated with the menstrual cycle. Next slide. And so now we've quantitatively validated the findings of our focus group. We estimated that approximately 1/3 of women with sickle cell disease experience acute pain associated with their menstrual cycle. And so next we sought out to prospectively evaluate the temporality, the temporal association between acute pain, dysmenorrhea, and the menstrual cycle. Next slide, please. So in a single center study, we gave patients mobile applications and chargers so that they could track their sickle cell pain, menstrual cramping, and menstrual cycles in real time using these applications. So they were asked to use the mobile application for 5 minutes every day over a 6-month period. We recruited 39 participants. And again, the goal was to really study this prospectively in real time to understand the correlation between these three entities. Next slide, please. And so after using mobile applications to prospectively study the association between sickle cell pain, menstrual cramping, and the onset of menstruation, we wanted to investigate the biological association between acute vaso-occlusive pain and the menstrual cycle. Next slide, please. And in thinking about, interventions that may help acute pain associated with menstruation, we wanted to look back at the prior literature to see what had been previously done. And there are studies as old as the 1970s suggesting that progesterone-only contraception therapy is effective not only for suppressing the menstrual cycle, but also for reducing acute vaso-occlusive pain episodes in women with sickle cell disease. So this further reaffirmed that suppression of menstruation may be beneficial in a subset of women who have frequent acute pain episodes that are associated with the onset of their menstrual cycle. Next slide, please. So we hypothesized that fluctuations in estrogen and progesterone during the menstrual cycle may actually be triggers for the onset of acute pain. And this looks at the follicular and luteal phases of the menstrual cycle. And you can see that as a follicle is developing, estrogen levels increase. And then when ovulation occurs, the luteal phase begins and estrogen levels begin to decrease and markers of progesterone increase. So we hypothesize that menstruation occurs when these hormonal levels are low. And we hypothesized that there was a link between the drop in estrogen and progesterone levels as seen here and the onset of pain with menstruation. Next slide, please. And so why or how would decreases in female hormonal levels be associated with the onset of pain with menstruation? One potential mechanism is that, again, menstruation does occur when progesterone levels are low and estrogen levels are low. And this has been, decreased estrogen has been associated with decreased nitric oxide levels. And so nitric oxide is really important for keeping a blood vessel dilated and protecting the endothelium. And so that helps to prevent, vaso-occlusive pain episodes. So if you have nitric oxide depletion, you have a constricted blood vessel, more vaso-occlusive events or blockages of the blood vessel, leading to end organ injury, ischemia, and the sensation of pain. And we noted in the literature that injury to the vascular endothelium can actually be measured by markers like leukotriene E4. Next slide, please. So our next step was to sort of test the feasibility of measuring estrogen, progesterone, and leukotriene E4, a marker of inflammation in the urine of menstruating women with sickle cell disease, who are also using mobile applications to track the onset of their sickle cell pain and their menstruation. And essentially in this study, we wanted to see if decreases in estrogen, progesterone, and leukotriene E4 were associated with the onset of sickle cell pain associated with the menstrual cycle. And this highlights the data from one patient who was very good about using her mobile application daily to track her symptoms. We can see here that initially, she has no very low levels of reported sickle cell pain. And then you can see here that her progesterone levels, which is PDG on the y-axis, are very high, and then precipitously drop as expected with the onset of her menstrual cycle. And then with the onset of her menstrual cycle and the drop in progesterone levels, her sickle cell pain changes from 0 to 6 to 9 out of 10. And so this does show a correlation between the onset of the menstrual cycle, a sharp decrease in progesterone level, and the onset of sickle cell pain, suggesting that progesterone may have a somewhat protective effect. Next slide, please. And so some lessons that we learned from these studies, there were definitely barriers to the collection of daily urine specimens to measure estrogen and progesterone levels. It's easier to measure urine samples because the patient can collect the samples at home, and we had couriers come to the patient's home twice a week to pick up the samples for measurement. And we did give these patients a small refrigerator to store the samples, but some patients were still reluctant to store urine specimens at home. And the collection of urine specimens and the timing became cumbersome to some patients. So, we reduced the frequency of urine specimen collection to once a week to mitigate that. And then some of the barriers we noted with the mobile application were that it was easy to forget to use every day, particularly over a 6-month period. And this was not an application with reminders on their personal cell phone. It was a separate cell phone device and mobile application. So it was easy for patients to lose track of, whether they had completed the app that day. And so we had decided that for future studies, we wanted to send daily text messages to participants' actual cell phones and also perform weekly adherence checks, because the adherence to daily use of the mobile application was only 51%. Next slide, please. So to summarize our approach, to test our hypothesis that acute pain associated with the menstrual cycle is real, we qualitatively characterized the differences between acute vaso-occlusive pain associated with the menstrual cycle and dysmenorrhea in 3 focus groups. And then we quantitatively estimated the proportion of women who experience acute pain associated with menstruation in a discovery cohort who used paper surveys. And then we replicated this research in an independent cohort using online surveys. And again, this was a more generalizable population of women across the country who were not necessarily followed at a tertiary care center. And these 2 studies confirmed that approximately 1/3 of women with sickle cell disease experience pain associated with the menstrual cycle. Next slide, please. And then we confirmed the temporal association in a prospective study between acute pain and the menstrual cycle using mobile applications, where patients entered on a daily basis whether they were on their menstrual cycle, whether they were having sickle cell pain, and whether they had menstrual cramping. Next slide, please. And then we measured serial biomarkers, estrogen, progesterone, in menstruating women with sickle cell disease. We had intended to run leukotriene E4, which is associated with inflammation and pain in sickle cell disease, but unfortunately there were issues with the assay. Next slide, please. And so this led to sort of the big, more important question of what can you do about menstruation-related issues like cramping and pain and sickle cell disease? We clearly convinced ourselves that the problem existed, but now we were faced with finding a solution. Unfortunately, there are no evidence-based guidelines to date for the management or prevention of acute vaso-occlusive pain associated with the menstrual cycle. Um, NSAIDs, heating pads, contraceptive therapy have all been used in clinical practice. I have had a few patients who told me that they were hospitalized so regularly for such severe pain associated with the menstrual cycle that they considered or underwent hysterectomy procedures after having children to prevent this problem. There really are multiple gaps remaining in the management of menstruation-related morbidity in people with sickle cell disease. Namely, we need to develop a better understanding of the role of targeted therapies and non-pharmacologic interventions. We treat this problem often with, with opioid medications that don't specifically target the actual mechanism that's causing pain. And we need to develop a better understanding of sickle cell disease, disease-modifying therapies like hydroxyurea and blood transfusions, and how they actually impact pain with the menstrual cycle. In our cross-sectional studies, they didn't seem to have an impact, but I do think it warrants prospective study to help counsel women better. And then all therapies must take into account the desire for fertility and childbearing. Next slide, please. And so the next steps occurred in partnership with some fantastic colleagues in Jamaica, in Kingston, Jamaica. So I want to acknowledge Dr. Zachary Ramsey and Professor Monica Asnani at the University of West Indies. They were a group that I met with through the Foundation for Women and Girls with Blood Disorders. And I imagine many people on this call may be familiar with this group and may collaborate with this group. This is a fantastic group that funds research on an annual basis focused on women's health and sickle cell disease. So I got this award, I think it was back in 2017, and Dr. Ramsey received this award in 2021. The foundation introduced us because Dr. Ramsey was very keen on developing a better understanding of the mechanisms leading to increased sickle cell pain, acute and chronic, as well as neuropathic pain in menstruating women with sickle cell disease. So I was excited to partner with this group, and I'll talk a little bit about some of the work that we did in collaboration with the Sickle Cell Center in Kingston. Next slide, please. So the aim of this study was to look at the association between sex hormones, namely testosterone, progesterone, and estrogen, and thermal and mechanical pain thresholds in menstruating women with sickle cell disease. So in this study, to give the 10,000-foot view, this was a prospective cohort study of 125 women in Kingston, Jamaica with sickle cell disease. And we included women with regular menstrual cycles and excluded women who were on hormonal contraceptive therapy for at least 3 months, who had amenorrhea or who were pregnant. And all women did take a pregnancy test prior to enrolling in this study. And so in this study, serum and blood measurements of estrogen, progesterone, and testosterone were taken at the luteal and follicular phases of the menstrual cycle. And then we used something called quantitative sensory testing to measure pain thresholds to mechanical and thermal stimuli. So quantitative sensory testing is not used in clinical practice, but it's a research tool that's used in pain studies to basically expose a participant to varying degrees of a painful stimulus. And it can be heat, it can be a mechanical stimulus. And essentially, you increase the stimulus until the participant reports having pain and needs to withdraw from the painful stimulus. So this is used to measure pain thresholds. So if you have a lower pain threshold, you essentially withdrew from the painful stimulus sooner. And then while measuring pain thresholds using quantitative sensory testing and sex hormone levels, we also measured chronic pain, neuropathic pain, dysmenorrhea, and frequency and severity of acute pain episodes using validated questionnaires. Next slide. And this again shows the variety of measurements during the follicular and luteal phases of the menstrual cycle. And again, these are all the questionnaires that we used to identify various subsets of pain in this population of menstruating women. Next slide, please. And so we hypothesized that dysmenorrhea and lower serum estrogen levels were associated with increased neuropathic pain, chronic pain, and severity of acute pain when measured across the ovulatory cycle in women with sickle cell disease. And this is based on again, prior data suggesting that that a number of women experience sickle cell pain with the onset of their menstrual cycle when estrogen and progesterone levels abruptly decrease. Next slide, please. And so these are our preliminary results. Dr. Ramsey is currently in the process of preparing for publication, but essentially we had 468 women who were approached for recruitment, of which 125 were included. There were various reasons that women were excluded. Some decided not to participate, but other women were on hormonal contraceptive therapy or found to be pregnant, so they were excluded. And then 106 women completed all study measures during the follicular and luteal phases of the menstrual cycle. The mean age was 29 years old for enrollment, so not too dissimilar from the previous studies we had done in Nashville, Tennessee. Hemoglobin SS was the most common genotype compared to the other genotypes. And then we found that pain was reported on most days over the last 3 months by almost 50% of women in the follicular phase and 40% of women in the luteal phase. So an overwhelming number of these participants did report having pain on most days, which was higher in the follicular phase. Next slide, please. And so other international studies have also confirmed that acute vaso-occlusive pain associated with the menstrual cycle is not only a real problem, but they went a step further to show that it's associated with increased hospitalization rates, which is something that we had observed clinically in our patients as well. So this is a study that was performed in collaboration with international groups, including groups in the US and a lead author in Ghana. And this was a multinational cross-sectional cohort study that used a validated questionnaire and medical chart review to sort of capture what percentage of patients who regularly experience sickle cell pain with their menstrual cycle are getting hospitalized. So they looked at 178 women total, and 39% of them reported having menstruation-related acute pain events in their lifetime. And those women who had menstruation-associated sickle cell pain were significantly more likely to be hospitalized compared to those without sickle cell disease pain during their menstrual cycle. And 40% of women reported at least 4 menstruation-associated pain crises in the past 6 months. So again, this is an international study that also validated that the onset of the menstrual cycle is associated with pain and hospitalization in women with sickle cell disease. And so with my colleague, Dr. Pecker, we thought very carefully about knowledge gaps and future directions with respect to reproductive health and women and girls with sickle cell disease. And we have a very long table in this manuscript relating to all aspects of the reproductive lifespan of women and girls with sickle cell disease. But I wanted to highlight some of our thoughts about menstruation, dysmenorrhea, and acute pain. Specifically, we have published data that, the acute vaso-occlusive pain is temporarily associated with the menstrual cycle, and that dysmenorrhea is a risk factor for having sickle cell pain with the menstrual cycle. But in terms of future directions, we highlighted that optimal hormonal contraceptive therapy to treat and prevent menstruation-associated pain is not very clearly defined. And the pathophysiology of acute pain associated with the menstrual cycle is also not defined, which prohibits us from using targeted therapies to treat this problem. For contraceptive study, there are published data for contraception. There are published data that unintended pregnancy is common in women with sickle cell disease, but barriers to treatment acceptance represent an opportunity for future investigation. And there is a dire need for care structures to prevent unplanned pregnancies and to improve access to contraceptive therapies for other purposes, including menstrual suppression and the reduction of acute pain associated with the menstrual cycle. Next slide, please. And so no guidelines currently exist to define the optimal treatment or prevention of acute vaso-occlusive pain associated with the menstrual cycle. And this led to some of the work that I completed with Dr. Asnani, Dr. Kim Smith-Whitley, and other experts in the field to use the Phoenix toolkit to expand data collection measurement tools to specifically measure clinical outcomes for reproductive health studies in sickle cell disease. And if we go to the next slide, I'll detail what the Phoenix toolkit outlines. So again, this is a freely available web-based catalog of data collection protocols, and it's available to any investigators anywhere. And the goal is to really promote and standardize outcome measurements for patient-oriented research. I've put the link in here that you'll have access to with the slide set. But essentially, you can research any topic that you're interested in pursuing further. So you can put sickle cell disease and menstruation. And this study will populate all validated protocols that have been published to measure the outcome you want. So in the toolbox, I put sickle cell menstruation, and you can see here all the validated protocols to measure sickle cell pain with the menstrual cycle pop up. So I just wanted to highlight this as a really important toolkit that's free, available, and can help to standardize and advance patient-oriented research studies in sickle cell disease. Next slide, please. I wanted to also highlight the importance of establishing multidisciplinary care teams and medical homes to really improve and address reproductive outcomes in sickle cell disease, such as acute vaso-occlusive pain associated with the menstrual cycle. And I'll highlight 3 separate studies that have been published. They're phenomenal, and they've shown the benefit of a multidisciplinary care team and a medical home. Next slide, please. So I want to highlight first some of the great work that's been done by the University of North Carolina that will be presented at ASH this year. They conducted a cross-sectional study at UNC between June 2021 and December 2023 of 54 women ages 19 to 65. And they implemented a joint sickle cell disease and GYN clinic for these patients. And they specifically wanted to compare rates of access to gynecologic care before and after the implementation of a joint sickle cell disease GYN clinic. And they found that once they sort of merged these 2 clinics together, 2/3 of women were started on new contraceptive therapy. 2 of them switched contraceptive therapy. And the majority of these women received contraceptive therapy on the same day as the clinic encounter when they actually got counseling. So this was really a venue where counseling and the actual care were merged in a convenient and accessible way for the patient. And all 30 patients, in this study period, completed a GYN appointment on site. And this was, a 3-fold increase from the year 2016 to 2017. When only 1/3 of patients were actually able to complete a GYN appointment in a year's time frame. So this increased patient access to counseling, to contraceptive therapy, and to GYNs in a coordinated multidisciplinary effort. Next slide. This is another study that confirms basically the same, that having a multidisciplinary sickle cell disease and GYN clinic actually improves access to GYN care and contraception. So this was a retrospective cohort study of 133 women who are followed in the University Hospital's hematology clinic for sickle cell disease from 2011 to 2015. And you can see here that the percentage of participants with sickle cell disease using contraceptive therapy before and after this multidisciplinary clinic was implemented increased from 12.3% all the way to 37%. So again, having a medical home where the patient can access their GYN care and sickle cell care in close proximity can massively improve access to contraceptive therapy to reduce morbidity from the menstrual cycle. Next slide, please. I want to highlight also some great work that was done in Accra, Ghana by Dr. Eugenia Asare. She implemented a multidisciplinary care team in Accra, Ghana that reduced maternal mortality substantially for women living with sickle cell disease. And so this was a single center retrospective and prospective study where Dr. Asare and her colleagues noted a relatively high rate of maternal mortality in pregnant women with sickle cell disease. So they decided to implement a multidisciplinary care team of obstetricians, hematologists, and pulmonologists, and specialized nursing staff who were very familiar with the management of sickle cell disease. And the use of regular incentive spirometry for pregnant women with sickle cell disease. Previously, there was no incentive spirometry used on the floors. And they wanted to compare maternal and perinatal mortality before and after implementing multidisciplinary care teams on the inpatient floors for pregnant women with sickle cell disease. And this was performed from January 2014 to May 2016 at Kolebu Teaching Hospital in Accra, Ghana. And before intervention, 158 women were followed in obstetric clinics for 16 months. And after the intervention, the patients were followed in combined sickle cell disease and obstetric clinics for 3 months. And so you can see that before and after the implementation of the multidisciplinary inpatient and outpatient clinics, there was a very dramatic reduction in mortality for the pregnant women with sickle cell disease. And this again really highlights the importance of a multidisciplinary care team to address reproductive health-related morbidity in women with sickle cell disease. Next slide, please. This is a picture of Dr. Asare on the left. Was very proud to see her present these findings at the American Society of Hematology meeting. I think it's rare in any field to see an intervention that reduces mortality by almost tenfold. So just wanted to highlight her here. And then on the right-hand side, I was with one of my mentors, Dr. Adetola Kasim in Accra, Ghana, shopping and enjoying the very beautiful culture of Ghana. And then at the bottom, this is a picture of Kolebu Teaching Hospital in Accra, Ghana, which is a national referral center for sickle cell disease in the city of Accra. And it was truly a pleasure to visit and see sort of firsthand how sickle cell disease is managed in a middle to low resource setting. Next slide. So back to our patient, she started on Depo-Provera, progesterone-only contraception. She's no longer having menstrual cycles. She's experiencing less frequent acute vaso-occlusive pain episodes overall. And she's able to attend more classes in pharmacy school and think more closely about the timing of her graduation. Next slide, please. So to summarize, acute pain associated with menstruation occurs in approximately 1/3 of women with sickle cell disease. Dysmenorrhea or menstrual cramping has shown to be significantly associated with having acute pain associated with the menstrual cycle. And NSAIDs and contraceptive therapy to suppress the menstrual cycle have been empirically used for the management and prevention of acute vaso-occlusive pain associated with the menstrual cycle. Next slide, please. Future studies to address menstruation-related morbidity in women with sickle cell disease are warranted to improve quality of life, and also to really identify targeted therapies to treat this problem. And lastly, there really is an urgent need for multidisciplinary care teams and the establishment of medical homes to expand access to care for menstruation-related issues like acute pain in people living with sickle cell disease. Next slide, please. I want to acknowledge some of the funding resources that have helped to further these studies for women with sickle cell disease, including the Foundation for Women and Girls with Blood Disorders, the Doris Duke Charitable Foundation, Thrombosis and Hemostasis Societies of North America, and Celgene. The work presented here wouldn't have been possible without all of these agencies. And with that, I want to say thank you so much for attending this talk, and I'm happy to answer any questions. And I also want to be thankful for the opportunity to be here today. Thank you.
Wonderful. Thank you so much for your presentation, Dr. Sharma. I found it really informative, a lot to take in, and really hopefully impactful for future discoveries and future work. At this time, we will begin to take participant questions. As a reminder for folks, we take the questions through the chat box or question function on the control panel for this webinar. And so with that, I'll give folks a few moments to answer some questions, and then I'll turn it over to David to get us started with Q&A.
Thanks, Leonie. I'm not seeing anything in the chat or in the questions section at the moment, but I guess we have a couple questions from the sickle cell data collection team here in California. Dr. Sharma, the first question that we have is, do you see an avenue for using administrative data set like the ones from SCDC to identify patterns of prevalence of menstruation-related pain crises among sickle cell patients?
Yes, I think the use of those data sets would be really helpful to inform the timing of an intervention to prevent acute pain associated with the menstrual cycle. I do think that those data sets would be really helpful.
Okay, awesome, thank you. And then a follow-up question, what variables or measures or other data collected would be essential to improve our understanding of the association between menstruation and acute pain for individuals with sickle cell disease?
If I understand your question correctly, you're asking sort of what tools and measures would be helpful?
Yeah. Mm-hmm.
Yeah. So there are a couple validated tools within the Phoenix toolkit that I showed, including the validated questionnaire that we use to measure acute vaso-occlusive pain associated with the menstrual cycle. And there are some groups that have that we've collaborated with that have sort of embedded that into the EMR to capture that in real time during a patient visit. So I think those are some of the ways to help use these standardized and validated protocol measures, integrate them into clinical practice for data collection.
Okay. Awesome, thank you.
Yeah, thank you.
We have a question from in the question box. What percentage of eligible patients in your clinic are on contraception?
That's a very good question. We found that during our study, when we looked at women of reproductive age who were actively, having menstrual cycles, that approximately 1/3 were on contraceptive therapy. So it was a good thing that we had expanded access to contraceptive therapy and counseling, but it did decrease recruitment to our study because we specifically wanted to study women who were not on contraceptive therapy. But in our clinic, it was approximately 1/3. And then it looks like in the in the study by the UNC group, we currently don't have a medical home of GYN and sickle cell disease in the same proximity or space, but it looks like that dramatically increased access to contraceptive therapy.
Thanks, Dr. Sharma. I'm not seeing, does anybody else have any other questions at the moment? Feel free to enter them in the chat or in the question box. If not, I'll turn it back over to you, Niani.
Okay, well, I'll give folks, thank you, David. I'll give folks just a few more minutes as I kind of close out to insert any questions they may think of.
A couple came in just now.
Okay, go ahead.
We have one question. Thank you, Dr. Sharma. As a HBSS patient in Nigeria, can this be shared with doctors so that hormonal contraceptives can be suggested as a treatment to reduce menstruation-related sickle cell pain?
I'm sorry, so you're asking if this can be shared with doctors in Nigeria?
Right, yeah.
Yes, certainly. The slide should be available to you, so feel free to share. And our group does work with collaborators in Nigeria for other purposes, for stroke prevention and to help bridge access to curative therapies in Nigeria. So I'm happy to also share these data with colleagues.
Awesome. Thank you. Okay, another question. Have you found any recognizable differences in the frequency of VOCs and menstruation between warriors in their 20s versus warriors in their 40s?
That's a really, really good question. In our study, we didn't find a correlation by age, but I think that warrants further study in a larger group. And I'm hopeful that the data from the group in Kingston that's a larger subset of patients that in Jamaica that was followed prospectively. So I'm interested to see if age played a role there. And I think that, another subset of warriors that hasn't been studied adequately is patients who've undergone menopause and how the frequency of acute pain episodes is affected. But that's a really good question.
Thanks, Dr. Sharma. I'm not seeing anything else come in, Niani.
Okay. Thank you so much, David. So if there are no further questions at this time, we will begin to conclude this webinar session. I have on the screen here a couple of different ways you can get in touch with our program. There's a QR code on the screen and find out a little bit more about what we're doing. Keep in touch with our webinars, newsletters, and just all things California Sickle Cell Data Collection Program. So I'll leave that up there for a few seconds. And feel free, after this webinar ends, you'll be prompted with a short 3-question survey where you can provide feedback on this webinar, as well as ask additional questions that might come to you at a later time, suggest future speakers, and provide more feedback for our speaker today. So if you fill that out, we would greatly appreciate it. I want to thank everyone who has joined us today, and of course a special thank you to you, Dr. Sharma, for presenting for us today. We appreciate you being here. We appreciate all who have attended. Have a happy holidays, everyone, and we'll talk soon.
Yeah. Thank you so much, Niani. Thank you, everyone, for attending, and wish you a very happy holiday.
Thanks. Bye, everyone.